Thank, thank you, everyone. Let me just start this up. Okay, try and get that.
Yep, go ahead.
Yeah, I've just got a black thing on the screen. Okay, so um, I'm going to talk a little bit about our challenges with some sim and the sim background at the Children's Hospital here in Calgary, Alberta. And then Corey Dowell is going to talk a little bit more about one area that we ended up doing quite a bit of sim on in procedure sedation. So we are a standalone hospital um, in Alberta, Canada, in the city called Calgary. We have 150 beds. We are at 14 beds that are pediatric intensive care and 15 beds that are NICU. We have a large emergency department that sees around 100,000 kids, and we cover a large area, not highly populated, but a significant area. Our sim center is located within the hospital. We're lucky enough to have it on the fourth floor, and we have 4 sim labs with 4 control rooms and 2 debrief rooms. And then in 2018, we got the ChildKind certification. So when I think about sim, I think a lot of people think sim as this traditional image where there is a large team, they're using a lot of big equipment, it's resource intensive, it's busy, and it's practicing. And sim certainly does include that, but there's other modalities of sim or other ways that we're using sim these days than just this big picture. So we can use task trainers where you're just zooming in and localizing on one area of a skill to be trained on. And that can be just learning the skill on its own, or it can be integrated within a sim where a patient needs an ultrasound and then you pull this mannequin next to them and they use that. You can also use sim actors. So this simulation actor is wearing a trach trainer, and so the learners are participating in suctioning and stuff. For us in peds, that's more tricky. So we end up using mannequins to do the suctioning and the training, and there's some pros and cons to that, but it is slightly more challenging. And then we can do sim looking at space and environment. And so reproducing it in an in situ. So not using the sim lab at all, but down in the real space. So this was a sim that we did to work out how can we improve the space that staff is working and making it more useful to them so that care is delivered at a higher level. So after this sim, we realized that there's a lot of storage units and cupboards that should be removed to make space for the whole team to work in appropriately. So improve the environment. And then another area of sim that isn't explored as much is the idea that we can use it for communication. So you can have either a simulation actor or a real actor acting as a parent, or maybe it's a staff member, and you have participants practicing the conversation, whether that's breaking bad news to the family or whether it's a parent is escalated and you're trying to de-escalate them. But those are sort of things. So not all of them need the beautiful sim lab that we're sometimes blessed with. They can be done in any space, any environment, and they don't have to use lots of resources. So areas of simulations we've done with pain was in our operating room area. We started doing procedural sedations in the induction rooms so that the child would come up, have procedure sedation, have the procedure done, and then be moved away again. Um, as I mentioned, Corey will talk more about the procedural sedation across the hospital-wide expansion, where every unit, every space was empowered to give sedation if it was needed, and you didn't have to just wait for this OR space that was premium, yeah, and used a lot, so it was hard to get into. Then when we started, we've adopted the commitment to comfort principles. And so when they started talking about comfort holds, it was a big rollout of using sim and the mannequins of how do you hold the children and what's the best way? And then working with the staff, let's say, who are taking blood, how do they hold and talk through with the family and the child of best ways to hold them instead of just pinning them down onto the bed that we had done traditionally. And so even if I acted as the mum and I had a infant mannequin and I was pretending to breastfeed, how would the blood people be able to manage to do their work? And it identifies areas that they struggled with, but also things that actually work for them. So we were able to work through a lot of the stuff. Epidural concerns have come up more recently where there's been some wrong rates and wrong solutions put in. And so simulation was done to sort of clear up this error and identify risks for staff to be aware of. And then we have medically fragile infants are often seen by occupational therapists, speech therapists, therapists, and we'll do sim to allow them to practice on these fragile infants that have lots of lines, lots of equipment attached to them, and how do they actually do their role? How do they pick them up and take them out to try and feed them? How do they turn them on their tummy to do tummy time? And the sim has allowed them to actually practice without dislodging lines, with feeling more confident, which means that end care of the babies is better. They're more likely to be picked up and have some of the care done outside of the crib instead of just everything done in the crib. As well as then what happens if you're holding the baby and something happens and they desat or they become bradycardic, how do you get them back safely into the crib, as well as calling for help? So just preparing them really. And then we've got a new standardized IV insertion course that includes anyone who's wanting to put in an IV has to be trained, and simulation is used in that to make sure that it's standardized and trained properly. So then when I think just an overview of principles of simulation, I'm not sure how much everyone knows. So this is just a quick overview. But when I think about simulation in healthcare, what are we trying to do? So we're trying to get everyone's experience that comes to the simulation, and then we're integrating it with the policies and the procedures and their previous knowledge and the knowledge that they have from whether they've just done a session. And then they're integrating it with their assumptions, their beliefs, their thoughts. And we're putting all those things into simulation. And we're trying to find out whether we can change routes and change behaviors and discover things that we didn't discover before. So that not only puts some of that new knowledge into long-term memory by practicing it versus just reading about it or being taught about it, but it also allows us to change concepts and perceive things. And so we saw this a lot during our surge. We seem to be hitting surge every winter these days, and the capacity in our beds are limited. So we end up having to double up patients in one room. Without simulation, the pushback from staff was huge. They were very negative about it. They didn't like it. It was unable to be achieved in their minds. By putting simulation and allowing them to walk through this process and come in with their own assumptions and beliefs, some of those beliefs and assumptions changed, and it has made it easier for them to accept and be prepared for when it happens. So by taking time to put them through some simulation, they were able to feel more prepared and come out on the other end. So I'm going to hand over to Corey.
Thanks. I think you set that up quite well. So, and talking through using simulation to support procedural sedation education was new to us, and did not come without its challenges. So, and I think thinking about ChildKind, commitment to comfort initiatives, the use of procedural sedation, I think in general that is a complicated thing to teach and sustain and to ensure knowledge translation. So we do approach it kind of at a multimodal. We do have a multimodal way of communicating it. So I think like we did policies and procedures, guidelines, resources. We use social media to do some of this education for nursing staff as well. I think additionally, just really wanting to think about how we can use simulation to help make this stuff a little bit more real and palatable to our staff. So I think kind of starting from the top, really looking at, okay, we've identified these resources. We think that this is how we should approach, a distressing or painful procedure. Can we use SIM to identify challenges in what that looks like? So human resource challenges, knowledge gap challenges, equipment, room, space. As Helen highlighted, really just using simulation to do something in a real environment, in situ, in a unit that would participate in something like this, mock that up and see what that looks like, have the nurses and the physicians really work through that, identify those challenges. Once those gaps have been made, you can change kind of what your approach is. You can change some of your resource guidance. You can fill those gaps, agree on a process and then and really using sim again to test what that looks like. So get it in the real environment. Well, do some, let's work through some scenarios. What types of procedures do you do that are considered distressing and or painful? How can we incorporate these elements into what that looks like? Test it with some teams, and then use it to educate and sustain that knowledge translation. I think that really is a challenge with this type of education. Again, thinking Helen really presented it well that when you think of sim, you think the bells, the whistles, you wait for the patient to code, you've got all these things happening. S- Sedation is not really like that. Really, it's just using the environment in this scenario to talk through and teach these people, to teach your clinicians how you can communicate through this and how you can plan a sedation event. I think that would be our next. Yeah, perfect. So we did have some successes with this type of education. It was easy to show people that it doesn't take that long. So a lot of the conversations around it were, well, if you're looking at planning sedation events, if we need to have our personnel, our equipment, if we need to talk about comfort holds and all teach the family and work with child life, it takes too much time. But doing it in the real environment and trying to simulate that environment shows the clinicians that it really doesn't take. Potentially pinning a patient down and, you know, physically restraining a patient takes more time in the long run. So it doesn't take a lot of time. It helped the nurses to really know how to empower and empower them to advocate for their patients. So, hey, have we thought about these things? Hey, I did a sim about this the other day. Have we thought about a comfort plan? Can mom hold this? Can mom hold her child in a certain way? We practiced that recently. Does that work? And I think that really helps with that knowledge translation as well, to have those people. You may not be able to have 300 or 400 staff or employees go through simulation, but I think those people that have had that opportunity, it really allows them to translate that knowledge to their colleagues. Hey, I practiced this. This is how we did it. This is what we talked about. And I think just being able to do that, and I think it really helped us to get people talking about it, get people thinking about how we can improve the management of pain and fear for the kids and the families that we see, and uh, how can we think about it? It should be in the forefront of what we do. And having them work through these things in real time in a simulated environment gives them that opportunity to talk through it and think about it and hopefully translate it into their practice. So I do think that it helped us to start that process and help start beginning to help people think about it and integrate it into their practice every day. It was also not without its challenges. So, like we talked about, um, the big thing that we found that while we were kind of trying to incorporate ChildKind and sedation conversations and things into simulation, it's hard to simulate with a mannequin that a patient is distressed. So that is a challenge, right? To talk through those things. We did do some simulation with some of our resident education, and one of our physicians filmed her daughter. She just did some filming with her daughter at home, just, pretending that she was distressed and, kicking and crying and that sort of thing, and just acting through that. And it helped us really to simulate what that looks like. So walking through, hey, this is your patient, you attempt the procedure that we are working through, and now this is what you see, show the video, what does that look like? And I think that really helps to generate those emotional feelings that they are going to experience in real time. So if that they're experiencing that in their daily practice, it generates those emotions. It's like, oh, what do we do? How do we do this? We have to get this done. This is really distressing for everybody. But using it in simulation allows for them to talk through those emotions and what does that look like and how do we address it? I think that really was a big success for us in that, but it's hard to sustain that, given that it's hard for us to find people to act right in pediatrics to try and simulate those types of procedures. So yeah, it makes it a little bit challenging. I did talk about looking at simulation using ChildKind in simulation or in sedation type of scenarios, you don't need necessarily a big group of people. If you're simulating a code situation or a trauma simulation, you need a lot of people. You have a lot of people involved. You need a lot of people to take on roles. If you're doing a simulation like this, it's a little bit smaller. It's a little bit more controlled, and you don't need all the people around. So you can only really accommodate a small amount of learners, making it hard to capture large amounts of people. But as I said before, using the simulation, it's a win if you get some people in there, a small amount of people, and you start to translate that knowledge that those people have experienced it in simulation and they can bring it to their daily space. Um, Limited in situ space available, so we have struggle finding space on the units to facilitate some of these things, especially if we're in a surge environment or a time where we're busting at the seams with patient care needs. There's not a lot of space on the units and the patient care areas that can do simulation, and I think really to be successful in these sorts of things with these types of simulations, it's important to have them in their real environment. How do you find your resources? How do you talk through these things? Who needs to be there? How do we get them there? And how much time does that actually take within my environment? It's easy to simulate it in a simulation environment or in a sim lab. But I think really getting them in that environment helps to trigger those emotions and those thoughts. And then I think really to be successful, we've talked about this a lot as we've kind of worked through our ChildKind and kind of worked through looking at how we prioritize pain as an organization. I think pain management, better pain management needs to be looked at as an organizational priority. And how do you fit this sort of stuff in any sim that you're doing? So it's not necessarily a sedation or commitment to comfort simulation. It maybe is a trauma simulation or some other simulation, but how do you incorporate pain management strategies, pain management language into your debriefings as an objective for everything? Similar to hand hygiene. You talk about hand hygiene and you try to incorporate those into your simulations. How do you do that with your pain approach? I noticed that you did a painful procedure on that patient. How could we have done that differently? How could we approach that differently? I think there's so many good opportunities in any sim that you do to incorporate these types of things into your objectives. And this is just an example of a scenario that we created. So, as I said, I've done a lot of different kind of approaches to this type of education. So we have done it in the sim lab, like I said, with our resident educator or with our resident team and some nurses involved, very multidisciplinary. We presented the scenario. So this is your case. Tommy's a 5-year-old. He needs an IV. He's had some, significant medical trauma in his journey, and this is what you are kind of presented with. You need to get this IV in. How do you navigate this? We use videos. We try to navigate some of that. I've also done education just on the unit as a case, like just a case presentation. So done the same thing. This is your scenario. How do you approach it? Where do you find your resources? How do you determine if you need sedation for this kid? What things do you consider before approaching this IV? How do you work through those things? So almost like a tabletop sim without all the bells and whistles. So really just kind of working through what this looks like and setting them up. This is your order. You've been ordered 5 milligrams of Madaz. Who needs to be there? What do you need to do before you administer it? Just talking through those things. And then obviously working them through the scenario to escalate it as you need it. So this is the patient. They think of, does this kid have a comfort plan? Did you put on topical anesthetic? Do you have child life? Do you have distraction? How can mom hold them? If your learners have worked through those things in your scenario, you can, great job. The IV went in, it went well. If they don't talk through those things, you can escalate it, right? To, now your patient is fighting, pulling away. What do you do? And I think talking about, okay, let's stop, let's take a step back, and let's talk through this again, and how do we work that? So really just looking at changing your scenario as you go through and really observing your learners and trying to figure out what that looks like. And I think the biggest bang for your buck is your debriefing and talking through, oh, how could you have done that differently? What language could we have used differently to help, support that patient better? It's it's not it's not a quite as fancy as a normal sim would be, but just trying to be creative and working through some of this education, if that makes any sense. Um, yeah, so I think just really looking at practicing through their comfort language, um, letting them do that, letting them identify that you can actually plan through these things. I feel like oftentimes in a healthcare environment, when we're looking at doing these procedures on kids, they're painful, they're distressing, but we just need to get them done. We don't have time to do these things, but that's often a misconception. So simulation and working through and talking through it allows them to know that they can actually practice working through this stuff. They can be planful about what they're doing. Um, and yeah, stuff like that. So talking through that. And Helen, I don't quite remember what we talked through with this slide. So if you wanted to jump in with anything I've missed, please feel free.
No, I think you're good. Yeah.
Okay. And I think just looking at incorporating it with everything that you do. So, and I think looking at future planning, right? Can we have pain management courses that integrate simulation that all staff can work through? Again, it comes back to organizational priorities that the management of pain and anxiety and medical trauma in our population needs to be a priority, and we need to be teaching our clinicians how to better navigate it. Um, really looking at commitment to comfort principles in all of our interactions. So I talked about using simulation, including commitment to comfort principles, including pain and comfort language in all your scenarios, no matter what you're doing. And I think that translates into everyday practice that I meet these kids. It could be the first time they are, accessing healthcare. How do I set them up for success? Oh, I practice that. I know how to do this. I can frame this experience for this patient so that it sets them up for success moving forward. This is a successful procedure. Maybe they do need to have a little bit of sedation the first time just to help take the edge off. What does that look like? And then really looking at how we incorporate evidence-based pain strategies into everything that we do. And I think that that's going to be your success is trying to do that instead of, oh, we're going to have this pain specific simulation that drives your learners to think about that stuff. Can we have another distracting scenario? The bells and the whistles are distracting. We should still be thinking about comfort and pain management. So how do we incorporate those and have those conversations?
Great. Thank you, Alberta. That was great. And we'll have time for questions at the end, but I'm going to go off and ask Wade to come up next from Dell Children's and give us his thoughts.
Sure. Yeah. Thanks for having me. That was a great talk. I appreciate that. It's helpful. We have a very active sim department at our hospital. We're fairly early in terms of pain specific or pain topic related sims, and so it's nice to hear some of that. And I was going to discuss a specific pilot that we're working on, that we're kind of working through and kind of go through how we got there and what our experience was. And I was going to echo a lot of the themes that you guys had talked about before. So it's kind of nice to see that, and there'll be some repetition. But so we have our department has done a few kind of pain like specific related sims. I know recently there was one where it was regarding the use of the chemotherapy drug naxitamab, which can cause pain with infusion, and so we have a protocol for that. And so the scenario was based off of working through the protocol and how do you escalate and when do you escalate, and there were different patient kind of changes throughout that, and it sounds like that one went really well. The one I was going to talk about was one that I worked on specifically with one of our quality coordinators that arose from one of our nurses on the surgical unit had voiced an opportunity for improvement in how better when she works on the surgical unit, and specifically looking at drain removals, chest tube removals, and how the communication went through those, who was involved in those, and what kind of preparatory work we did in regards to those. And so our child life specialist did some local education with the nurse practitioners and the other providers and the nurses, but a lot of it was more didactic focused, there were a lot of questions about, well, so when you talk about these non-pharm pain management strategies, one voice, what does that mean? How does it work when I'm doing the procedure, if I'm the one person supposed to be talking? And so a lot of practical questions. And so that's where the idea of SIM came from. How do we work through some of these questions that you have in real time in a simulation so that we can apply them to actual patient encounters? And so we worked with our SIM center and created a SIM centered around bedside drain removal for a patient. And we picked a 5-year-old patient. And so the team that was involved with the SIM, we had a general surgery nurse practitioner, our child life specialist, we had bedside nurse, and then we had a simulated patient, which was the mannequin in our case, and then a parent, which was an actor. We had volunteers from some other nurses, and I did a few of them. And so the sections of the sim were, the first part was that the team had to huddle and discuss what the strategy was for pain management during this removal. And then after that, so pain plan, medication plan, if we're going to use one voice, or what are our non-pharm management strategies, and who's going to be the primary kind of voice in the room, et cetera. So figure that out ahead of time. And then discuss that plan with the parent, and get some specifics about the child and what they like and don't like, that may be helpful in terms of improving the experience. And then actually doing the procedure. During the procedure, we had pain escalation, some parental anxiety escalation because of that, and how we navigate that. There's some little parental frustration within that. And then afterwards, the debrief. So the things that we've learned, we've done it probably, I don't know, I think maybe 6 or 7 times so far. Learned something with each time. Each time's a little different. I think one is that the quality of the sim is based on, how much you put in it, that's how much you get out of it. And so I think it can be a little awkward sometimes when you are trying to navigate with people, and so some of the challenges with the procedure itself and using the mannequin and all those things. But the more that the participants were involved in the scenario and kind of invested in the scenario, the more we took out of it. The actor, the parent, how convincing they were, I think made a big difference too. I have a needle phobic kid, and I'm a kind of an anxious parent, so it was really easy for me to slip in that role and do that. But so it was variable in that, and so I think a little bit more standardization that would be helpful. The other thing that I think was interesting that we've discovered with this scenario is that most sims involve nurses, doctors, kind of respiratory therapists, those kind of things. But it was the first time our child life had been involved in this simulation. And that kind of floored me a little bit because of how much they do at our hospital. And she had no idea what to expect. And so I think there's certainly an opportunity for us to consider that more, especially if it's simulations around procedures, or where they're going to be playing an active role in helping provide comfort for the patient, or help with distraction, or help with any other kind of mediation. Where do they stand? What is it? How do we interact with them as the providers? What are good language suggestions? Those kind of things I think was really helpful, and having their input was really invaluable in the debrief. It was great hearing the things that they came up with during the debrief that we weren't used to thinking of. And so I think that would be one thing that I would suggest. The other the other main point is how the role of the debrief and how important that is. And I think, I would echo what Helen and Corey were saying, or especially Corey when he was talking about, it doesn't have to be a pain specific sim to talk about pain, and a really high yield way to kind of introduce the discussion about patient comfort would be to add a bullet point in every debrief, and it can be about a specific procedure that's happening during the scenario, or just say, was there anything additional we could improve, we could do to improve patient comfort during the scenario? Was there an opportunity that we thought about or saw? And it could be a very, tag it on at the end and see what that leads, and get those thoughts flowing while you're reflecting on how the scenario went. I think our kind of next steps or opportunities to kind of expand a little bit or work through that is, I think there were some things with the sim that we learned as we did it, as more and more, so to tighten up the scenario, to figure out how to provide a little bit more kind of involvement with the bedside nurse, because a lot of it was child life specialist, surgical nurse practitioner, and parent, kind of the dynamics between those three. We had a bedside nurse there, so figure out how we could use them more and how they could get a little bit more out of it in this scenario. So figuring out roles and what the asks might be, and then kind of variations on that. I think expanding outside of general surgery perspective, and reaching out to some other bedside procedures that we do. And I think there are a lot of opportunities. I liked before when they were talking, I had a vision of what SIM is, but it's so much broader than that. And I think there are a lot of creative ways to kind of introduce pain principles or work through different pain management strategies using simulation. So that's kind of.
Thank you, Wade. That was very helpful. And now, Sharon, tell us about Nationwide's experience thus far.
Hello. Share my screen. Okay, so we are, I would say, the babies in the simulation. We started our formalized simulation center here at Nationwide Children's Hospital in Columbus right around COVID time. So that definitely took a little time to get, up and running, especially with staff trying to separate. But we do have a conference center and a formal simulation lab. And then we also have a simulation room that can be right on the campus, because our conference center and our simulation lab are across the street, but sometimes that makes it challenging for staff. So our simulation that we're working on is a library for more inpatient pain management nursing simulation. And so Rachel Badovic and Alexa Ganter, nurse practitioners with acute pain service, and very instrumental in helping to create this for us. So why did we choose these? We have always strived on excellence in management and safety with providing pain management. So prior to 2020, we would have a whole day opioid, sedative, hypnotic live session class. We would teach those sessions along with pharmacy, and we would talk about all the different opioids and pain management. After that, the nurses had to take a post-test and get an 80% or higher. But COVID changed that for us. And so we went to an online module. And then we had a change in thoughts from our education department that tests were stressful for nurses. Nurses weren't passing the test. So they eliminated the test for nurses, which I was kicking and screaming, but I didn't have input on that. So we had asked initially about, can we do some simulation type of stuff? And we were told no, but we didn't take that for an answer. And as we continue to see increase in patient event reports related to pain management, nurses not understanding different analgesics, misprogramming pumps, and things like that, we follow that and track that. And then, as I'm sure everybody else as Joint Commission, we continue to have issues with PRN, analgesic dosing and pain, and not matching scores. So a year ago, we went and we submitted another request to the simulation lab of why we thought this was important, and they actually approved it. So we used these 5 principal phases for the curriculum development. And our project team, we have our acute pain service, advanced practice nurses. We had nurse educators from a lot of the floors in the hospital, our simulation center staff, who's been amazing, and we've learned so much from them. Bedside nurse involvement and nurse manager and supervisor involvement, since we're really focusing on the nursing staff with our current simulation. So what we did for the analysis is we sent out survey monkeys to the inpatient nurses, clinical educators, and managers, asking about it, kind of a needs assessment. We really wanted to know, did they take the IV opioids class? Did they find it was helpful, not helpful? We asked if it was helpful for certain types of management things. We wanted to know would side effect and adverse effect with opioids and analgesics be helpful, if they wanted something, the difference with acute and chronic pain, how to explain that to patients and families, withdrawal. We left a lot of open-ended questions about different pumps that we use for analgesia, how comfortable they were. And then what do you feel the most uncomfortable with non-opioid analgesics? We use IV lidocaine, ketamine out on the floors now. And so we were trying to see how comfortable the nurses were with that, and then medication calculation. So once we got feedback, we decided to hold focus groups and kind of discuss the general survey results. And then we narrowed it down to what scenarios they thought, because we can't tackle the world all at once, would be the most helpful. And so we landed on 5 simulation scenarios. And so our first one is pump programming and setup. And so when we used to have the in-person IV opioid sedative class, we'd bring the pain pumps, we'd bring the epidural pumps. The nurses got to play around with setting them up and practice, and we would help them. And so there really isn't a lot of opportunity besides whoever's teaching you on the floor to learn, and maybe it's not in the best environment unless they call the pain team to help out. So that was an area that everyone felt we needed that. The PRN pain management, and how do you utilize the meds you have, and when do you need to call for more, and when can you not give things because it's not really written that way. So that was the second scenario. We have pump of errors. And so we have pumps that are like misprogrammed and clamped and all of that stuff. So that will be a pump of errors. We did epidural management, and we picked a baby because we also were doing a lot more regional and NCA pumps in our NICU area. And so we thought, especially with epidurals, babies are harder to evaluate how things are working. And so we thought we'd make it more challenging case for our initial case. And then our last one that we are going to have in our initial simulation scenarios is lidocaine toxicity. So then we worked with, once we decided which ones we were going to have, then we had additional focus groups. If people wanted to help give input onto each of the groups, what they thought was really important that we covered in the scenarios. And so that was extremely helpful. We took a lot of notes, and then we sat down with our simulation center team, and we developed each simulation. And so it was pretty cool to go through this process because none of us had gone through that process before. So we definitely learned a lot when we were doing this. And so this simulation, we have a 16-year-old female on the GI service, belly pain, frequent occurrence of pancreatitis. And so this one, we recommended a PCA pump. So how do the nurses set that up? What do they do? And what we also learned when we were doing a dry run is it might be an opportunity to go through the beginning, because we fast forward a few hours and then we fast forward the scenario 2 days. Okay, we're ready to stop the pump. So how do you document it all, and waste and all of that controlled substance tracking and everything? So we have decided we're going to, as we're moving, fast forward and then allow someone to update some of the equipment in the room and get us to the right place. We'll have a little discussion with the nurses as we're working through the scenarios. So we have developed our pre-brief, and so exactly what we're going to have, and our post-brief questions for each of the scenarios, and then a summary for that. So That's what we've developed. So we're still early in the phase. We're also going to do, I told you we had the IV opioids test that the nurses had to pass. And so there is no knowledge piece to determine do they understand things. So we are going to do a pre-test with 5 to 10 questions for each of the scenarios to kind of assess where their knowledge base is for the different scenarios. And then we will do a post-test with the same questions 2 months after the scenario and see if there's more retention in where there might have been deficits in the knowledge base. So we did a dry run last week with the scenario, and like I said, it was able to help us learn. It took a little while for our Epic builders to develop patients for each of the scenarios in our Epic playground so we can actually utilize Epic. We'll have the medications, water, but bags that will match exactly what we would have in the patient. So I think it's going to be pretty interesting, but we haven't really done it yet with the staff. So we are still really early in this, but listening to what everyone else is doing, we're super excited to get this moving forward. So again, an evaluation, we'll have our pre and post testing. We'll do feedback from the debriefing, and we'll be sure that we capture that information. And then we plan to look for additional simulation modules to create in the future. We are getting ready to use dexmedetomidine more frequently in other units outside of the ICU, and kind of maybe opening it up a little more for symptom management. So I can see that certainly be a simulation that would be really helpful for the nursing staff, and definitely opportunities for more than nursing. Our palliative care does have some scenarios where people can go in and have discussions with patients and families for end of life discussions. But listening to what all you guys are doing as well gives me a lot of great ideas we can do in the future. So
Thank you, Sharon. That was great. And you can see the variety. You can take the slides down. Oh, there we go. You can see the variety of different opportunities there are in SIM, and certainly please feel free to raise your hands or put a question in the chat. It strikes me, that one of the most challenging things that I think for trainees, and whether those physician trainees, nurses, or other specialties, it's communication around pain. And I'm going to ask Wade, because I know as in his role he probably works with a lot of trainees. Have you developed scenarios, or are you thinking developing scenarios where you're really putting the resident in a case where they're dealing with a patient in pain, and how they have that discussion and how they ask the questions? And probably you need almost an actor or something in that role to really, because we all, those of us experienced know some of those situations can be incredibly challenging. So just curious about your thoughts about that.
Yeah, I mean, absolutely. I think, we do a little, with our training orientation, there's a little bit of conversation, or there's a little bit of role-playing exercise with just difficult conversations in general. But I think that, there are certainly opportunities for specific, conversation topics, in using SIM for that. A lot of, what we do, is kind of debriefing after conversations, or kind of preparing ourselves in real time. But it's nice to kind of go through some of those concepts and teach them how to come up with what's your maybe strategy here, or what what the opportunities are for recognition within that. But yeah, absolutely, I think there's a great opportunity for scenarios in regards to that. The one that I talked about as part of the debrief, we kind of focused on with our team, how what was the when the parent kind of escalated, do we feel like that we handled that appropriately and helped kind of what might have been other strategies we could try, or what and I think there's a great opportunity for residents as well. And taking that scenario was specific for procedures, but I mean, really any pain discussion or anything that we talk about on bedside rounds, you could substitute the same thing. It's not adrenal removal, it's abdominal pain, and we haven't been able to kind of get it under control with the medications we have, those kind of things. I think there's a lot of opportunity with that.
Yeah, cool. And again, any questions, feel free to raise your hand. Paula said, why don't you go ahead and say what you said, Paula, rather than
Thanks,
reading
Bill.
what you said.
Yeah, I just find that I love this because, we're not just talking about trainees, we're talking about staff. And that's really sometimes a more difficult challenge because there's not as much education around that. And also getting them to go places they're not used to because they're not students anymore. But one of the big things is pain management is usually such an interdisciplinary and a professional approach. And what I've heard a lot is that you've brought together nurses, child life, MDs, nurses, RTs, whoever. I noticed there was someone who mentioned social work is many times not included, which when you're having conversations, depending on what they are, would be around pain is perfect to include. But leveraging this interprofessional learning as well, because I think the more people get comfortable within the interprofessional space, it will actually increase some of their empowerment to advocate for kids. So kudos to you guys for doing this.
Great. So a couple other things, we have and I couldn't show these videos today, but we have a researcher who uses video and animated videos to create virtual cases. And I'm sure with AI and everything, we're going to see more of that. Is there anybody doing anything in this group with kind of virtual scenarios where you have the one that we've done it's a research study around sickle cell disease. So, and comparing, we have a couple different patient video. They're not cartoons, but they're animated. They're not real patients, but although I think Jen Stinson a number of years ago did some of that with, again, videos, but with JIA patients and talking about pain and stuff. So those I think can be useful. And I don't know if anybody's seen The Pit, which is on Max in the US. I don't know if it's on in Canada. It's, if you recall, Noah Wiley from ER. I think you could probably do a lot of training around what they do right and what they do wrong for physicians and clinicians. They actually had some they had a sickle cell case and talked about sickle cell disease, which was fairly well done. They during trauma, they're always talking about opioids and giving opioids. So kudos to them. So, it's not all accurate, but anyway, so, you might want to use some clips from The Pit if you want to do some of these. Has anybody else, we have a lot of places from other institutions. Anybody else want to raise their hand and talk about any simulation that they've done at their place? Feel free to chime in anytime. This is often a very quiet group. I do know a couple names on here. I might just have to call on somebody like Rayanne Kingsley.
There's actually
And we have a
hand.
hand up. Yep.
Oh, we have a hand up. Rayanne, you've been saved. I can't see. Oh, there it is. Dolly, go ahead. Tell us where you're from and go ahead. I think you're on mute, Dolly. Still on mute.
Oh, yeah, we still can't hear you.
We still can't hear you, Dolly. You're off mute, but I don't know why we can't hear you. All right. I'll let you keep working on that, Dolly, and now I'm going to pick on Rayanne. Rayanne, anything you're doing in this world, or what are your thoughts on this? Would you consider it Rayanne's at Kansas City? So,
oh my goodness, Bill, that was just something. I think it is an area that we recognize as a need, and again, trying to determine is it something that I think the way Wade presented is much more of an organizational approach and tying it into the simulations that we already have, which are very individual role based, which makes it a challenge too, because you do need to involve all of those other roles, and trying to navigate having the right people and the applicable people in the room, but not to deter from the simulations that are already happening and the purpose of those. I think that's the challenge that we're really at, and finding, you know, obviously everybody always says there's not enough hours in the day, and we need to make sure that it's value added, which I think all of us would argue, any of this information is definitely value added.
Thanks, Rayanne. Appreciate it. So I'll read what Dolly said, unless Dolly, you've been able to get on the speaker. But what Dolly says, I'm an educator at McMaster. I did a sim for my surgical team while we rolled out one of the revised plaque pain use of the revised plaque pain assessment tool. So that's certainly, just working through pain assessment can certainly be something that you can do. Uh, um, I hear a voice.
I have one other idea that popped in my head as you guys were all talking. So, we have our pain clinics and our intensive pain rehab programs, and someone talked about parents, and I thought, oh my gosh, school avoidance. And how do you get parents? How do you help them feel empowered? And how do they work through getting their kids to school? And I'm like, wouldn't that be the best scenario to do simulation for parents to have them practice getting a kid that's super challenging to school? And what do you say to these kids? And so I love the thought about parents and simulation, because I think you can show them videos, you can talk to them, but I think that whole role modeling or a simulation would be invaluable for that type of a situation.
I think it'd be great for helping them advocate for their children too during hospitalization. We do a lot, and part of ChildKind is how do we educate parents and how do hospitals educate parents. So doing a sim with parents so that they feel empowered to say, hang on, no, I'm going to breastfeed my baby, or they need some pain medication or what have you. Because I think we give them that. I think you're right, Sharon. I think we give them a lot of education on that, but no practice part. Yeah.
So just a couple of other comments that were, unfortunately, as people are chiming in, now we're getting close to the end, but at East Tennessee, Knoxville, we developed a multidisciplinary simulation palliative medicine end of life, which of course, includes pain and symptom management. And I do think that those are great situations where sim and case-based approaches could be really helpful. Joelle Fawcett Arsenault says, I think using a patient family story prepares folks for simulation is powerful. Also, Simona from Boston Children's gave a link for the comfortability videos, and which is on the comfortability website. Includes a school meeting modeling. Terrific, Simona. Thank you. So all great ideas. Unfortunately, we're going to have to wrap up now. But thank you very much. We do these quarterly. For those interested in learning more about ChildKind, if you're in Meredith, you can get on our website. Meredith is a person to reach out to. She can talk you through the initial stages of ChildKind certification. We'd love to learn more about your institution and provide you the opportunity to meet with us and talk about how we can help you move forward. So thanks very much. Have a great rest of your week, and hope to see you someplace soon. Take care.
Thank you.